All right, let's rock and roll here. I don't have anything to disclose either, except I do work for food, especially Community Q Barbecue. I do work for ribs. And I do promote giving blood. Everybody get blood? It's a good thing to get. All right, you're excited about it. All right, here's where we're going. We're going to go for the red cell, white cell. Woke you up, didn't I? Platelets. All right. Finger stick crit. Nobody ever does one, but if you ever did, you get the capillary tube, sticks a drop of blood in suck it up. Put it clay side out, otherwise the blood goes all over the wall if you don't put clay in the bottom. Spin it. What do you get? You get basically a hematocrit. The amount of red over the total juice is the hematocrit. The most common cell is your red cell, so it'll be the hero. But then there's this buffy coat that separates the plasma from the red cells, and that's your white cells and platelets. Only 1%, but they're pretty important, aren't they? Yep. All right, white cells, they're your infection fighters. So they move inside and outside the tubing, the superhighway. If red cells do that, what's it called? Bleeding. Yes, it is. That's wrong. Okay, we don't want bleeding. What's your job as a junior hematologist? Keep blood in the tube and keep it flowing. But white cells can leak because we want them to get to the hot spot and go get bacteria, leak, and go out. And it's made in the bone marrow. Different kind of white cells. So if you got a leukocytosis or a leukopenia, you want to know, what is my differential? I want to know how many segs I've got, bands, lymphs, monos, eos, and basos, and maybe some atypical lymphs. Do they all give you clues to what's happening? Yes, they do. High band count, what are you going to say? Bacteria. High seg count? Bacteria. High lymph count? Anything, virus, everything else. Okay. What about monos? What do they go up in? Mono, yeah, mononucleosis, but there's one that's even more common, but they go up in chronic infections like HIV, SBE, TB. EOs go up in what? Two things to think about. Allergies and parasites. Don't drink the water when you go camping. All right, and atypical lymphs. That's the mono one too, okay? You get these big, ugly-looking lymphocytes. So if you see clues, and on any on the pants or pantry, they will give you normal lab values, right? So if they give you labs, they'll give you what's normal, so you don't have to memorize. Oh, that's ugly. All right. Your platelets, what do? Plugger uppers. They're your first line of defense against bleeding out. Made in the bone marrow. We'll talk about them in a minute. All right, there's that red cell carrying oxygen. Everybody breathe in. Oxygenate. Breathe out. Carbon dioxide, feeding the trees. Yep. All right, normally the life of a red cell is 120 days. Around and around it goes. It is a major buffer for your blood, keeping your pH stable. Contains the protein hemoglobin. The red cell don't do nothing except transport hemoglobin. It's a fluid-filled, floppy taxi cab. Hemoglobin's doing all the work. You got to have a little iron, folate, B12. Hey, that's the next talk coming. We're giving you some nutrition right after me. All right, so that's coming to have those healthy red cells, and it's made in the bone marrow. Do you see a theme here? Red cells, white cells, platelets, all made in your bone marrow. So if all three are low, where you going to go? Didn't that rhyme? Yeah, so you'll never forget it. All right. The bottom line test for this whole thing is you're going to get a bone marrow biopsy, right? See what the factory's doing. But you can do a lot of peripheral tests before that gets to that point. This is what red cells look like under a microscope. It looks like a hole in the middle, but it's a biconcave disc. It's thinner there, so it can go through the really tight spots in your body. Like this is a capillary out in your pinky. Your pinky wants oxygen. So that red cell has to elongate, go around curves, get into some tight spots so your pinky gets oxygenated. What makes red cells rigid? Anybody know this disease? Alan worked at it for 20 years. Sickle cell. There you go. All right. I'll give you some clues. All right. Red cells, again, carrying that hemoglobin. That's annoying, isn't it? So you got 4 iron-containing heme groups that actually bind the gas. So that's what's binding your oxygen inside. The squiggles of protein are all coded by your DNA. So hemoglobin is actually imprinted. You're born with your DNA of what you're going to make for the rest of your life, what kind of hemoglobins. Little biochemistry, don't throw up. Okay, it's just a little. But basically, your hemoglobin is coded on chromosome 16 and on chromosome 11. You get a pair from mom and a pair from dad. And whatever you got, that's the kind of hemoglobins you're going to make for the rest of your life, unless we do something radical. Anybody know we can be radical? Can we cure hemoglobinopathy? Any DNA mutations, like sickle cell, can it be fixed? Yes, it can. Okay, anybody heard of bone marrow transplant? Stem cell transplant? Yeah, it's pretty radical, isn't it? But if somebody's messed up in the bone marrow, making the wrong kind of DNA, basically there's any kind of mutations, we may put that person heading to bone marrow transplant. And that's been done over thousands of sickle cell, thousands of thalassemics. The genetic cure would be going in and actually doing surgery on the DNA, giving it back to the person with the same stem cells. Wouldn't that be awesome? Do you think it's going on? Happened in France. First kid was cured with his own DNA manipulated with CRISPR technology. Wowzer. Okay, that won't be on the boards, but that's just kind of fun. All right. So anyway, where do you get, basically everybody in this room has 3 hemoglobins in those red cells. Usually it's type A, F, and A2. A is the main workhorse, F is fetal, A2 is just kind of hanging out there. Okay, very little, but hey. Depends on which chains you put together to make that hemoglobin. Usually everybody's got alpha. If you don't have alpha, you're dead, okay? You just don't make it. So really, if you don't make enough alpha chains and you have 4 factories here, if one gets nuked, no big deal. 2 get nuked, well, I can still make about half. You get a little anemic, a little microcytic, but you can go fine. Mess up 3 and you're highly symptomatic. Okay, mess up 4, you're dead. So that's called alpha thalassemia. Thalassemia means I don't make enough of the chain, so my hemoglobin's low. Doesn't mean I'm bleeding out or anything. It's just a DNA problem. The #1 cause of worldwide genetic anemia is thalassemia. It ain't sickle cell. Sickle cell is often grouped in that. So sickle cell is basically a beta chain mutation. Then there's several over here because beta is your main normal adult hemoglobin. And if I don't make enough beta chains, that's called beta thalassemia. Again, the most common anemia genetically worldwide is thalassemia. Might there be questions? I don't know, but if I were thinking common, you would want to know that. They're all microcytic, and they look like iron deficient, but your iron stores are usually normal. That would be your clue. And you would do DNA or you'd do electrophoresis. The main test to see what hemoglobins you got is the hemoglobin electrophoresis. If you know that, you'll know there's other methods, and your lab may say, well, we don't do that. We do isoelectric focusing. You say, great, thank you. But just tell me what's inside those red cells. So you need to know that, and anybody who comes in with a genetic lifelong anemia, mommy's anemic, daddy's anemic, brother's anemic, what do you say? I smell genetic here. So get the test, electrophoresis, right? All newborns in the USA get tested. Not all countries do that. So if you weren't born in a hospital, you may not have got tested. So if in doubt, get the test. It's pretty cheap, and you want to know that because it doesn't change unless you do bone marrow transplant. All right, red cells, white cells, platelets, all made in the marrow. The bottom line test for this is bone marrow biopsy. You get a needle, sucks them out, see what's going on in there. All right, the retic. This is a juvenile teenage red cell just squirted out of the marrow. It matures in 2 days and then is a happy red cell for 120 days, going round and round and round and round. Your retic is the best indicator of how your bone marrow is responding to an anemia. Let me say that again. Your retic is the best indicator of what your bone marrow is doing to respond to anemia. What should it do? Go up, right? If you're low, the bone marrow should be kicking off and going, the retic count should go up. So if I'm low in hemoglobin and I've got a high retic, you're losing red cells somewhere. How do I lose red cells? 2 ways. Bleeding, hemolysis. So that's a great clue for you. If my retic count's low and I'm anemic, what's wrong? Where's the problem? Bone marrow, of course. See how this is not rocket science. It's all good. All right. Red cells, again, a little physiology. You got to eat right. B12, folate, iron, get it in your gut. Goes to the marrow where you make your red cells. Do you know red cells don't have no nuclei when they're out circling around? Do they have a nuclei? Back in the marrow they did, because that's where they made their hemoglobin. Then once you made your hemoglobin, out goes the nuclei. Get rid of it. Once it's squirted out, it's a retic. After 2 days, it's a mature, out and out, around it goes. All right, but you have a recycling plant. It's usually in the spleen and liver where old red cells go to lyse because they get friable and they break apart. You reclaim everything. Basically, hemoglobin's broken down to a product called bilirubin. Anybody met Billy the Rubin? Okay, 2 flavors of bilirubin, right? Direct and indirect. Little jingle. All my students know this one. What is that? Bilirubin must be directed through the liver to get conjugated. All right, say it with me. You'll never forget it. Bilirubin must be directed through the liver to get conjugated. So direct bilirubin's been touched by the liver, making it water soluble so you can have a cheeseburger tonight and it'll digest it. Okay? Make sense? Indirect bilirubin's all pre-liver. It's trying to get to the liver to get conjugated. High-end direct bilirubin's one of 2 things. Hemolysis or Gilbert. Everybody say Gilbert. Don't say Gilbert, you're embarrassed yourself. Well, it looks like Gilbert, but it's really Gilbert, okay? It means I don't process bilirubin enough, so I'm always a little jaundiced, always have high indirect bilirubin. Life is wonderful, leave them alone. They don't have hepatitis, okay? So, again, that's the recycling plant, is the spleen. So we got to break up that. Now, another actor in this big play is hepcidin. Anybody heard of hepcidin? It's a hormone secreted by the liver. Again, the liver makes everything. But it's upregulated in inflammation. So we heard all about inflammatory everything. Remember with Janice Herbert Carter? All those inflammatory, SLE, rheumatoid, you name it. If your body's inflamed, this goes up, and basically iron is locked away and cannot be used. It is locked in the storehouse, which is mainly your liver and reticular endothelial system. You can't use iron. You can't absorb iron. So you may get what? You may basically have enough iron in your body. It can't get to the marrow to be integrated into hemoglobin. We used to call this inflammatory block. Okay, now we know the culprit. There's actually, science is trying to make a hepcidin blocker. It's actually in clinical trials. So hopefully we can help these people who have inflammatory block and have chronic disease and have anemia from chronic disease. Okay, so that's a biggie. So anyway, moving right along, science is good. How about the kidney? You heard all about that too. Kidneys make pee, but they also make erythropoietin. Remember what that does? It basically tells your bone marrow to make more red cells. And how does it know to do that? When your oxygen level in your kidney gets low, out goes EPO. EPO circulates back to the marrow saying, turn it on, guys. I need more red cells. So anything that makes you hypoxic over time will cause an increased EPO, which should cause increased red cell production. Now, how can we mess that up? This is America. We can mess up every organ in our body, right? How do we mess up kidney? What goes wrong? Diabetes, hypertension, anything, again, all those things Dr. Herbert Carter talked about with renal disease, especially chronic renal failure, no EPO, that's a reason they're anemic. Can we fix that? Yay, we have recombinant EPO now. So again, you don't want to go too high or go too fast. Remember, slow and low, but you can bring somebody back up to hemoglobin's about 10 and they do much better. You don't want to go too high because they get viscous, hyperviscosity, stroke, and bedness. Okay. So anyway, the kidney is involved. We got to check it out. So one of your differentials on a normocytic anemia is check renal function. What's your BMN creatinine? That may be your answer. Okay. Moving right along. What's your history? They come to you weak and dizzy. All right. You heard about dizzy last night. If you stick around, remember? He said, "What's the question you ask?" The room spins, doesn't it? It's a loaded question. Please make the room spin because I want vertigo. I don't want the other workup because you're going to be there till 10 p.m., right? Okay. So weak, tired, fatigued. Don't you feel that way right now? 4 days of board review? Yeah, me too. All right, you get dyspnea. That means, why? Because you have fewer red cells to carry oxygen, so your body feels short of breath. And palpitations because your heart may be beating faster to get what little red cells you got around quicker. So you get more, you may feel that presence of your heart beating quicker. You may have new angina because now you've got a narrowing, but now you take away red cells and now the heart gets a little starved. So these are all ways. It's very insidious, but keep it on your radar for everything. There you go. All right, so what's the history? Always ask, what are you doing for pain? I never ask what medicines you take because people are taking concoctions, right? All right. And what's the number one painkiller in Georgia? Come on. BC powder. I think that's number 2. Come on, NASCAR people. Goodies, number 1. Okay, goodies and BC powder. Well, what's in those? Number 1 ingredient is aspirin. What does aspirin do to you? I feel good. I don't have pain. Okay, hole in the tummy. I feel good. No pain. What's the blood doing? Leak, leak, leak. There ain't no platelets working. Platelets are dead because aspirin is the most potent platelet killer on the planet. Okay, so I got a hole, bleed, bleed, bleed. So how can I get anemic GI bleed because I'm taking aspirin products? Do you see the connection there? So always ask about aspirin, NSAIDs, but I say, what do you do for pain? That's a kind of global way to get it. All NSAIDs block platelets, but it's reversible. Aspirin is irreversible. Once your aspirin's on board, those platelets are gone. Okay, 9 days, you need a new crop. Ask about pica. What's a pica? Furry little animal? No, it's when you eat things that ain't normally et, and you got to get kind of the patient alone and say, let's be serious here. Are you eating clay? Are you eating ice overabundantly? People eat some strange stuff. We had a guy brought to Grady, well, his parents brought this child and said, chief complaint was Johnny ate the sofa. I was like, what? Yeah, they just bought a new sofa from Target, and he was, the bottom kept going down and down, and he was reaching in, unzipping the cushion and eating the foam rubber. He had foam rubber pica, so yep, it's out there. Also, we're doing surgery on people. Anybody heard of bariatric surgery and bypasser? We're making people, again, lose lots of weight, but what are we bypassing? All the ability to absorb B12 and iron. So what are we generating? A group of thin, iron-deficient, B12-deficient people who will come see you with anemia. So I always say, what happened to your belly there? What's that scar? Anyway, moving right along. You can read all that. A lot more on my slides that you need to go back and look at. I can't hit them all. Look at the eyes. The eyes have it. Why? Pull down the lower conjunctiva and look. Is it pale or is it pink? Next thing, is your sclera white and is it yellow? If you're pale and yellow, I'm saying ding, 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 what? Hemolysis from jaundice, which is probably indirect bilirubin. Both direct and indirect bilirubin both look yellow. Just want to let you know. The only way to tell the difference is a blood test. Okay? Both of them make you yellow. So if you're jaundice and pale, I'm thinking that's probably you're breaking red cells apart. Isn't that a good clue? Eyes have it, 2 seconds. Boom. All right, moving right along. That's yellowness, okay? And that, I can't see pallor there, but anyway. Spoon nails, good for putting sugar on your cereal. That's iron deficiency. Okay, what else? Chelosis, glossitis. So a good general inspection will help you with anemia. Start at the head, go to the toes. Basically, your vital signs will tell you if somebody's bad enough to admit and then transfuse. Go on, you don't treat a number. What you're going to do is treat how how symptomatic is your patient, right? So basically, you want to do orthostatic blood pressures. If they're orthostatic, they're going in and you're getting type and cross. Okay, that's time you do want to pull the trigger. So vital signs really kind of put you in that idea of I think this person needs to be tanked back up with packed red cells. So the transfusion trigger isn't done until the patient's that symptomatic, okay? It's not on a number. You want to be very conservative about blood because there's issues with giving blood, right? We'll talk about those in a minute, okay? Anyway, start at the head, go to the toes. Lots of clues to consider. You're going in, put on 2 gloves because where are you going? The rear. What are you doing? Still guaiac. Why? Number 1 place people bleed and don't know it's the GI tract. So you need to do that. All right, so anyway, do a whole exam. Head to toe, do a little neuro, just a little bit. Okay, what do you need? Vibratory sense and position sense. What if they're gone? What would do that? That shows up. I'm saying ding, ding, ding. B12. Yes, B12 affects your posterior column. So that would be an immediate thought. All right. Good thought. Okay, what labs do you get when somebody's anemic? CBC? Oh, thank you. I have one. CBC retic. Say them together like one syllable. CBC? That's slow. CBC retic. Put them together. You always need a retic to see what is your bone marrow doing with this anemia. So you need to know that when you're monitoring therapy, when you're doing diagnosis. So CBC? Thank you. All right, you're almost awake. All right. So you get a red cell morphology, have a human eyeball, look at the smear. Okay, do a red cell smear and look at the cells, please. You want a white cell differential if it's low or high. You want to get a UA. Why? Because the kidney's important. It makes EPO. You want to get a basic metabolic profile because that's where my LDH and my bilirubins live, my liver, enzymes, and my renal, BUN and creatinine. So I want to pay attention to all those. If it smells hereditary, I get a hemoglobin electrophoresis. Now, all babies should have had it if they're born in the USA in the last, say, 20 years, but maybe they didn't. Okay? And if you're bleeding, PT, PTT, PFA, we're going to talk about that in a minute. You don't need to know normals. Again, the test will give you normals. This is just normal adults. And kids, you need a nomogram, right? Because they change over time. So really, don't have to memorize those. I look at, again, what is the hemoglobin? That's the one I want to know. Crit is basically 3 times the hemoglobin should be the crit, kind of gauging your labs. But really, they don't give you a lot of clue. MCH, MCHC, all are cute. Cute. This is the one I really want. MCV. How big are my red cells? That's going to guide me in like a missile what diagnostic test I'm going to get for this patient. Are the cells too big, too small, or just right? Just like Goldilocks, okay? So those are ones. If you have a high RDW, that may mean you have a mixed picture. Small cells and big cells, and you could actually have an iron deficiency and a B12 deficiency. Wow, those patients. Would they do that to you? They might. So that's a clue for that. Smears tell you a lot, so please get your morphology. You don't have to read smears, but a lab tech should, and if they come back and say, this is what we see, these are the things you think about. Again, you make the diagnosis of malaria off a smear, okay? So multiple clues there, so take a look. Platelet count, if you're too low, that may be why you're bleeding and you're anemic, so always check it out. And then retic count. It's going to be normal, high, or low. So that's what you want to look for. Again, if it's high and your hematocrit and hemoglobin are going down, you're thinking this person's bleeding or I've got hemolysis going on. If it's low, I'm thinking bone marrow. You may have to correct the retic. I gave you the math. Most labs do that. On the boards, they wouldn't make you do math. Okay, that would be absolutely cruel. So you should have a corrected retic. When you're in practice, you only want to look at the corrected retic. If your lab doesn't correct it, break them brownies and say, do the math, please. And then they'll do it for you. All right, and that's how you do the math for that. All right, diagnostic pathway. If you're anemic, first thing I want to know, what's your corrected retic doing? If it's under 2, I've got a bone marrow problem. That's where I'm going to go look and go fishing. And then on the next thing I want to know, what's your MCV? If it's low, I've got microcytic anemia. If it's normal, normocytic. And if it's big, macrocytic. And I've got differentials and lab tests for each of those. If I've got increased loss, I've got hemolysis. Next thing I want to know is, are you hemolyzing or are you bleeding? Bleeding ought to be obvious, like blood on the floor, blood on somewhere. Oh, you just got scooped up by a Mack truck and beat up and whatever. Or you just had surgery. That could be the clue. The surgeon left something spurting. So that's what your differential should be, and we'll hit there in a minute. But mainly, we're focusing on hemolysis over there. Bleeding's a whole nother talk somewhere. All right. Microcytic is where your anemia world will be. 90% of patients fit right here. So know this one. Your differential should be TICS, T-I-C-S. Everybody say it with me. TICS. Do the TICS. Now, that's not the blood-sucking kind. That's making a tick mark with a pencil. Little bitty mark, okay? T, thalassemias. Again, they're in this category because they're little bitty red cells, and I don't make enough alpha or beta chains. Then I've got iron deficiency. That is the granddad of all anemias. Worldwide, if you take all anemias, it's number 1. And third one, chronic inflammation. That's the one with hepcidin. Any inflammatory process in your body locks iron up, and it can't be used. Iron studies you do are normal, what you're going to do here, because iron's a big deal. And then sideroblastic equals lead poisoning to proven otherwise. All right, let's talk about these, because these may show up because they're common. All right, serum iron, TIBC, saturation, but I'd say the money test on this whole panel is your ferritin. Ferritin is what you got in the storehouse closet to use iron. Ferritin's low, you're iron deficient. Period, the end. Okay. So that's the one that will tell you, are you deficient or not? And then electrophoresis, because again, thalassemia is on this list. And if you even think about it, get a lead level. Okay, that's for lead poisoning. Kids just do it. That panel ought to include lead screening, because we can fix lead poisoning, right? Get the lead out. You heard that? All right. So that's your basic test in the microcytic group. All right, let's talk about thalassemias. Again, alpha or beta, microcytic anemia may have Target cells. See, they look like little bullseyes, target. Yeah, okay. Again, if they're symptomatic, punt them to a hematologist. That's where they need to go. They may need lifelong either transfusions or a bone marrow transplant. Most people are asymptomatic, but the tragedy is they get put on lifelong iron because nobody looked at their iron to see that it was normal or high, and here's iron pills, go away for 20 years and take your iron. They come back with a new disease. It's called hemochromatosis. They're about to die in liver failure, and their heart is dysfunctional, and all their endocrine organs are failing. So can we just tell you, iron is a poison if you don't need it. If you want to kill someone slowly over like 20 years, give them iron every day when they don't need it, okay? That's a bad thing to do. So can we stop iron if you don't need it, please? If you need it, you need it. But if you don't, stop it. Because again, too much iron over time pickles your liver, kills your endocrine organs, hemochromatosis, okay? So I've seen thalassemics treated this way, and it's kind of a tragedy when they come back and have all the mess. So those folks don't need anything. If they're asymptomatic, their iron's normal, go have a happy life. You're fine, okay? But the ones that are symptomatic, get them to a hematologist. Iron deficiency, you will see this. Again, low serum iron, but serum iron is what you had for dinner last night, okay? Serum ferritin is what you got in the storehouse. That's your long-term, what do you got to work with iron. Find out why. They may give you a case with a low iron. Do you stop and give them iron, say, see you in 6 months? You say, no way. What are you going to do? Work up their gut. Why are they losing iron? Basically, number one way is GI blood loss. So work up the gut. That may be that colon cancer that's leaking. That may be their peptic ulcer. Something's going on. So find out why. You treat them with ferrous sulfate, 300 milligrams. You can give them ascorbic acid. You're going to hear more about that in nutrition right after me. But basically, you replenish iron, follow their ferritin. Their retic count should go up in a week or two. Ferritin should be tanked up in a month or two. And once you got them tanked up and you fix the leak, okay, you've done your job, and you made sure there's no more leaking. Then chronic inflammatory. How do I know that's going on? Get a SED rate or C-reactive protein, either one. That's non-specific body inflammation monitor, right? If it's high, you're inflamed. I got to figure that out. But that may be why you're not making more red cells, because basically your iron is locked away. Your ferritin should be normal or high, because that's storehouse iron. That's not what you can get to the marrow to make new hemoglobin. Okay, it's locked up. Can't get to it. So 30% are microcytic, 70% normocytic. SED rate or C-reactive proteins up. Just cure that HIV, the rheumatoid arthritis, SLE, and this gets better. Okay? You got your mission? You can go do that. I think the new hepcidin blockers will probably be out maybe in a few years. So stay tuned for that one. Sideroblastic is, you may see this speckling pattern. That's called basophilic stippling. That's a shout out, kind of a clue. If the morphology lab reports as basophilic stippling, you say lead, okay? Lead, 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 lead. There's some hereditary genetic things that are very rare, but lead, lead, lead is common. How do adults get lead poisoning? Number one way in Georgia. Moonshine. Okay, moonshine. Don't drink the moonshine while you're here. It's made in lead line, whatever, but there was an epidemic at Grady. Yeah, it was from the moonshine made in the hills of Tennessee, brought to Atlanta, sold cheaply. But think about lead workers, battery workers, anybody who's been exposed, but mainly adult beverages aren't made well. Okay, kids eat dirt, so always screen your kids. We have chelating agents to get the lead out, because again, it can cause permanent brain damage, and we don't want to have that happen to anybody. So that's lead. All right, moving on to normocytic anemia. The differential is normal size. The ones I want you to think about are renal disease, okay, because renal means no EPO. Also inflammatory block. There's also aplastic anemia from like parvovirus, or the marrow just shuts down. Those are kind of the ones I'd be suspect about. What tests do you get? BUN, creatinine, again, look at that. Basically, it's a basic metabolic profile. Get a pregnancy test, please, just if you are in that genre, because, again, pregnancy can give you a normocytic anemia, and bone marrow biopsy if you can't figure it out from your clinical. All right, and renal failure, we can monitor that, you can actually get EPO levels. We can replace EPO with darbepoetin alpha or epoetin alpha injections. So that's usually the purview of the renal people. And again, aplastic, again, these are some of the causes to look over. Parvo's the virus called fifth disease. You saw it with the slap cheeks. Doesn't really affect normal kids, but somebody with a sickle cell or thalassemia, they can actually go into shock because their crits can fall so fast and they have no reserve. So that's something to think about. There you go. Macrocytic, big long differential, big fat red cells. I only want you to know two. BF, my BF. Anybody got a BF in here? Okay, got one home? All right, what's B? B12. The other, folate. These are your top two differentials, I would think, in life. And so think about that. So the test you want to get for this group is, again, a metabolic profile, but also a B12, it's serum folate, RBC folate. If those are borderline, there's a methylmalonic acid and a homocysteine level to help clue into B12 or folate deficiency. If those are normal, think about a thyroid profile, and a bone marrow biopsy is the bottom line for searching this out. Okay, but most of your folks are going to fall right up here, B12 and folate. And remember about the basically loss of position sense and vibratory sense of B12. Physical signs for B12, again, pallor, edema, jaundice, smooth tongue, decreased vibratory and position sense. Can you say circle that, star, star, star? Put that in your brain. And again, you get a low serum B12. You want to find out, again, why. We're doing all the gastric bypass and whatever. That may be the cause, but it may just be pernicious anemia. You can get an anti-intrinsic factor antibody. We used to do a Schilling's test, not more. Basically, you treat them. And you can start with oral, high level, see if they correct. If they don't, you're moving to a shot, okay? The monthly cobalamin, once a month. There is a nasal spray that works kind of, but basically I try oral first. That doesn't work, move to the shot. All right, folate, just replace the folate. Enough said. Boom. Hemolysis, what's your differential? Hematologist, which one should you think about? That would be common, again, sickle cell, thalassemia, G6PD, because you will cause that one, and transfusion reactions, okay? I would think about those kind of, the rest you want to punt to a hematologist. Another way to think of it is HIT. Hereditary, that's genetic, and that fits the sickle cell thalassemia. G6PD deficiency is genetic, but they're fine until we give them something and we set it off, usually. And then membrane problems like spherocytes and elliptocytes. Immune attack, that's complicated. IgG, IgM, I don't know. Complement goes crazy. The ones here would be antibiotics, drug reactions, transfusion reactions. So if somebody had a transfusion a week ago, it may be a delayed transfusion reaction hemolysis. Okay, usually the acute ones happen when you're given the blood, like immediately. But there's delayed ones that can happen several weeks later, and that could be what's happening. And then trauma to red cells. That's usually ICU stuff, so we'll talk about that when we get to platelets. All right, what's your signs you're hemolyzing? Your jaundice, high indirect bili, and a high LDH, lactate dehydrogenases. That's a slam dunk. I don't know if anything else does that combo. Liver enzymes are fine, but your LDH is high, and your retic is high, and your indirect bili is high. That says, screams at you, I'm hemolyzing. What test do you want to get next? Again, these are the tests. You get a Coombs test, hemoglobin electrophoresis. Heinz body stain is for G6PD, not for ketchup. That is to tell you, is that going on? You have to do that while they're hemolyzing. Do a schmear. Somebody look at the red cells, please, and get a platelet count in the CBC. Okay. Then what do? Okay, if it's sickle cell, get them to a sickle cell center. Yay, Grady's got one. Choa's got them. Everybody's got them. The thing on the for a question would be, what medicine may treat these? Well, hydroxyurea prevents pain, so it's a daily, lifelong medicine. A brand new one just got out, L-arginine basically, just got approved by the FDA. So there's a couple treatments that can actually prevent and help them live longer, so think about that. All kids need penicillin until age 6, and again, hydroxyurea prolongs life, so just keep those factoids. There's a website out there for that, yes there is. All right, G6PD. This is something I would be very suspect about. This is the case somebody comes in for their MRSA. They get Bactrim, which has sulfa and trimethoprim as a combo. They do better. Their MRSA is getting better. Day 2, they're yellow, weak, and dizzy. And you go, ruh-roh. And their hemoglobin's falling. Their retic is high. Their indirect bili's high. You say, what in the world did I do to them? Is this a drug reaction? You think G6PD. Any sulfa drug will set this off. It is basically, it's an oxidant drug. The hemoglobin inside turns into balls called Heinz bodies. This is what the Heinz body stain looks like. So you tell them, stop the drug. Let's change you to something else, and give them a wallet card. Never take these medicines, okay? Antimalarials, aspirin, sulfa. Don't eat those dreaded fava beans either, okay? Anyway, immune attack. I'll just let you read the slides. Basically, just think about transfusion reactions and drug reactions. And, yeah, there's all kinds, IgG, IgM. I think that's too deep for this. And then parasites like malaria and babesia, you do on a thick smear. Okay, depending on, do you know babesia? Where does that come from? Anybody seen a good babesia lately? That's tick-borne, yeah. What area of the USA has babesia? Cape Cod, yeah. So the scenario, I just had clam chowder at Cape Cod, and now I'm hemolyzing. You say babesia. Okay, anyway, move around. And that's spherocytes and elliptocytes, Mike and Ike disease, and beach balls. That's just pretty. Okay, moving right along. How about clotting? Let's get into that. Okay, your job as a junior hematologist, keep blood in the tubes. Think of PVC pipes. Anybody got those PVC pipes in your house? Do they leak? Yeah, you want copper. Why? PVC leaks and breaks. Yeah, I know. Okay, so think PVC pipes. This is your whole clue to all of clotting. P is for platelets. Do I have enough, and do they work? 2 questions you got to ask in your head. Von Willebrand's factor, the super glue of platelets. If I don't have any, platelets can't stick to broken walls and can't do their job. Clotting factors. I hate clotting factors, don't you? There are too many. I can't remember. There's cascades falling down a waterfall. And, All right. You need to have enough of them. And then your pipes need to be healthy. We learned about, again, things like temporal arteritis and basically vasculitis. Pipes can get ill, right? So your piping can be damaged or not work right. So you got to have all of these in working order to keep blood in the tubes. Again, what happens when you get a cut? All right, cut, ouch. Okay, your endothelium tries to contract, keep the cut smaller, but out goes the blood. Then first thing on guard, von Willebrand factor sticks platelets to the wall. Platelets go crazy. They recruit more platelets, release all of their chemicals that help set off the clotting cascade. You have fibrin threads start to form, pulls all the red cells, white cells, and platelets into a goo called a clot. Stops the hole. Then actually platelets have actin and myosin in them. Where else do you see that? Yeah, like here. Okay. Well, that's what platelets do. They group together and pull. Okay, pull the clot together. It contracts. Platelets are awesome. Anyway, little guys, but they do a lot. What happens when you clot in places that ain't cut? Well, that's called infarction. What happens downstream? No flow, dead tissue. So if that's your brain, you just had a stroke. If it's your heart, you had an MI. If it's down in your leg, you got a DVT that can break off and become a PE. So that's why we worry about the clotting system gone crazy. Endothelium is active and it's alive. It's not just lining your blood vessels, it's actually making stuff. It makes your von Willebrand factor, it makes TPA, clot buster. Nitric oxide keeps blood vessels dilated and platelets calm. So all these things are there to help you regulate the clotting system. So how can we damage endothelium? Cheeseburgers, right, yeah, anyway, cholesterol plaques, all those things, smoking, diabetes, all those things that interrupt endothelium. We want healthy endothelium. So, okay, von Willebrand factor is the superglue of platelets. The other thing it does is stabilize factor 8. Factor 8 is the glamour queen. Okay, there's a bunch of clotting factors. Remember, it goes all the way from 12 to 1, but there's one diva. What do divas do? They stand out. The diva. The diva is factor 8. It gets all the press. It gets all the glamour, but it needs a crutch. All divas need a crutch. The crutch is von Willebrand factor. It stabilizes it. If von Willebrand factor is not there, the diva can't do its job and it falls over. Okay? Get that little pictogram in your mind. Okay? So we got the diva. Okay? Factor 8. It's the #1 clotting factor problem that's low. That's called hemophilia A because it's the diva. But the number one reason people don't clot genetically is von Willebrand disease. Okay? It is the most common reason people bleed too much. And it is really the crutch because it supports factor VIII. And it keeps platelets stuck to walls. All right, keep that little factoid. The platelet makes, again, made in the marrow. Thrombopoietin comes from your liver. Can you say be kind to your liver, please? Okay, you tell your patients too. It makes everything. It makes all your clotting factors and makes your platelets. And so all those things go south, your whole clotting system goes south too. So again, thrombopoietin is made by the liver. You can actually supplement thrombopoietin now. Just like we have recombinant EPO, we have recombinant thrombo to help stimulate more platelet production. And again, you can see the happy life of a platelet's about 8 to 9 days, if it's healthy. Platelets get activated multiple ways. Let me count the ways. Collagen, thrombin, all those things. You have all kinds of receptors on the platelet. Why are these important? Because we have targeted drugs that mess with these receptors to block platelets from working. And we'll get to that when we get to therapy. What does a platelet look like? A little bitty ball, but then it goes crazy. Ah! So what makes it go from calm and cool to this? Okay, a cut. Okay, anything that, again, exposes it to collagen, ADP, or tissue factor makes platelets activate. Then they release all their chemicals, form long spindles, and look like the creature. All right, don't throw up. Here's the clotting cascade. All right, let me make this simple for you. Okay, there's a simple side and a complicated side. The complicated side has too many factors. I can't remember them, but the diva lives in the complicated side. Why? Because divas are always complicated, aren't they? They have a complicated life. So factor VIII lives over on the complicated side. Now, there's a wannabe diva called factor IX. It lives right above factor VIII. Okay, so factor VIII and IX are the two big hemophilias if I don't make enough genetically. Okay, so they're on the complicated side. There's a complicated test to measure the complicated side. It's called the APTT. Too many letters. Let me say it for you. Activated partial thromboplastin time. You say it 10 times fast. Can't do it, can you? That's because it's complicated. Complicated test measures the complicated side where the complicated people live like the divas. Got it? You never forget it. All right, there's a simple side, factor VII. It's so mellow. It's over there on the side. It is basically activated with tissue factor. It's activated outside the cut. Inside the cut is the complicated side, okay? So I have one test. It's called the PT, prothrombin time. I could say that 20 times fast, can't you? Yeah, it's simple. Simple test, simple side. It's the extrinsic pathway outside the cut, one factor, factor VII. Both of them feed the common pathway, and you got to make fibrin threads or else this whole thing don't work. So basically, von Willebrand factor stabilizes factor VIII. Remember, it stabilizes the diva. But which test would go south if I don't have enough von Willebrand factor? Would it be the PT or APTT? The complicated one. See, you're thinking like a hematologist. There you go. So that's all about the testing. Vitamin K makes these factors in blue. You got to have vitamin K. Do we have a way to mess up vitamin K? You just eat a crappy diet. What's the other one? There's a medication. Coumadin. So really, Coumadin is the one we've been using forever. That messes up these blue factors, which mainly we measure with the PT and INR. INR equals PT. Put that in your book, please. PT equals INR. It's just another way of reporting it. It either comes back in seconds or it comes back as a number 1, 2, 3. Okay. They're not a different test. INR is the PT. Okay? Everybody gets confused about it. I want an INR and a PT, and the lab will go, it's the same thing. All right, I know. Okay, so don't embarrass yourself. Okay, built-in clot busters and clot blockers. Again, you have protein S, protein C, tissue factor pathway, antithrombin 3. All these things keep you from clotting too much. And if these get deficient, you swing over to the clotty side. That means you may have DVTs recurrently. We can test for all those if somebody's coming in with their 3rd DVT, their 5th PE, and you don't know why. Okay, because it may be a genetic reason why they're clotting too much. And then you have clot buster. You make TPA. It's made in your endothelial cells to bust the clot apart. It's the only thing we've got to separate basically fibrin threads into split products. That's what D-dimer tells you. D-dimer is just clot being busted. You're basically lysing clot somewhere. You may be using your own TPA. Can we help you with more TPA? Yes, we can. But what does it do to all clots in your body? Poof. Okay, if you had one up here in your brain, what happened? All right, so that's why we be careful with TPA. But you make it. You actually have TPA. We just give you more if we need to. So how do people with bleeding come to you? Again, let me count the ways. Bleeding gun, bleeding, bruising, post-op bleeding, blah, blah, blah. Okay, you can read all that. How about clotting? This is all of medicine. DVT, PE, MI, miscarriages, all these things. Everybody in a bed is high risk for clotting, okay, like we heard from the pulmonary lecture. Okay, and then the bleeding history, you can go that. Bleeding from mucous membranes, you think of clotting, basically platelet problems or von Willebrand's disease. Bleeding into joints, you think hemophilia. If you've got big purpura all over the body, again, that may be any of those, but you think of vasculitis or vascular wall defects. And more in the history. Ask what they use for pain, because what's the #1 painkiller in Georgia? Goodies or BC. What's in it? Aspirin. Aspirin, and all your NSAIDs block platelets. So ask about that. So you can go through the history here. La, 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 la. All those things. Yes, smoking is bad. Just stop it. Everybody. Diabetes, stop it. Okay, all these things. Can we say most of your patients are high risk for clotting? All these things push you to the clotty side. Oh, I'm so sorry. Then physical exam. Start at the head, go to the toes, look at the skin, look at the mucous membranes. Going down through all that, you can review that later. Liver and spleen, please. Always check your lymph tissues, liver and spleen and lymph nodes. And you're going in, again with the glove, okay, looking for GI bleeds. And again, Homan sign is a total joke. Okay, even Homan wanted his name off of it because it doesn't work. But how do you recognize DVT? Basically, high index of suspicion, swollen calf, bigger size, tenderness, get the ultrasound. Okay, so if you suspect it, go for it. Try and rule that out. This is petechiae and bleeding into the tongue. Ouch. And this is hemarthrosis. Think about, again, this would be factor 8 and factor 9 problems. And then purpura, think vascular wall. All right, testing, what do? Test the PVC pipes. How do I know how many platelets I got? Where would that be? CBC. CBC tells you white count, platelet count, red count, right? So platelet count, do you have enough? Well, we'll go over that in a minute. How many is too low? We'll talk about that. What about do they work right? Does the CBC say those platelets work? No, you can have a normal count, but they're dead as a doornail. How do I know if they work? PFA, platelet function analysis. PFA says, do the platelets work? You got to have both, and you got to know both pieces of data. All right, von Willebrand's factor. We don't usually screen for that, but if I have an abnormal PFA and an abnormal APTT, ding, 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 one thing that does that is not enough von Willebrand factor. That would be my clue to go searching up that. If you suspect von Willebrand's disease, you call the lab and say, what can we do to diagnose that? Because a whole battery of tests, very expensive, maybe referral, but you want to suspect it. How do I measure clotting factors? The APTT, the complicated side, and the PT. Do I need a TT in there? No, not unless both are abnormal, okay? If one is abnormal and the other's okay, my common pathway's still working. If both don't work, then I got to check the common pathway because they both feed the common pathway. So most labs will say if your APTT is abnormal, your PT is abnormal, they will run the TT test, okay? That's thrombin time. So your labs are usually pretty good. They also may do a mixing study. That is giving back the person normal plasma and seeing if you correct. If my APTT does not correct when I give normal plasma back, I may have an inhibitor on board. Now that's high hematology. That's punt time hematologist. Help! Who gets inhibitors? It's usually like the hemophiliacs getting recombinant factor. They're building antibodies to those factors where are inhibitors that even though I give you normal plasma back, your body's fighting. Won't take it. I'm fighting you. Okay, that's an inhibitor. So if you see that, I think that would be cruel, but just in case. You may see that in practice. Punt to a hematologist. Okay, what gets low? Again, danger zone is, again, below 20,000 on your platelet count. You may be bleeding spontaneously. So that's when we really get excited. If you're over 1 million, we worry they're going to get together and clot too much. All right, so those are your tests summarized. We already talked about PT, APTT, mixing study, and what does that mean? Okay, platelet function tells you do they work right? And again, if you suspect von Willebrand's disease, there's a whole battery of tests. I just call the lab and say, what can we do to diagnose von Willebrand's disease? They will tell you. And that's another set of the bleeding workup, so you can read that. All right, clotting test for bleeding. I gave you some tables to kind of give you the, what do you think of when this is normal and this is not? So go back and take a look at some of those. I don't know of any book that's got that. I also added a table with the PFA added to the platelet count, because von Willebrand's is the only one I know that gives you an abnormal APTT and an abnormal PFA. Platelets ain't working because there's no super glue, and I've messed up the DIVA factor 8. So think about these, and this is a good differential for you if you work in ICUs. Keep this little card handy. Anyway, all right, for clotting too much. Is there any blood test that can screen for clotting too much? Heck no, there ain't no stinking test. How do we know if you're going to clot too much? You had your third DVT. Uh-oh. Now I better think genetic, okay? If it's unprovoked and you're having lots, then we do the screening. Otherwise, these tests do not predict if you're going to be hypercoagulable. If you've already declared it with an unprovoked clot, then we screen you for these genetic things. So they're very expensive. What do they mean? All it means is you may prolong your anticoagulation. Sometimes you give it for life. So that's your decision making, why you would get these tests. All right, and again, D-dimer just says clotting is being busted up, so you must have a clot somewhere in your body. That's all it tells you. It doesn't say where. You've got to have that clinical suspicion. You may see helmet cells too, schistocytes. That's a clue. Red cells are flying through fibrin threads and being sliced and diced. This is the differential for bleeding too much, calf dips. Okay, so you can look at all that. The other way to look at it is PVC pipes. Platelets, not enough. That's thrombocytopenia. Not working. I've poisoned them somehow. Remember, uremia will make platelets not work right either. Von Willebrand's disease, most common, ding, 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 most common genetic reason. Okay, clotting factors, most common is the DIVA, factor 8, followed by the wannabe DIVA, factor 9. Vitamin K deficiency, liver disease, hey, that's pretty common. And then inhibitors, pipes, vasculitis, and here's several things there. The ones I could think about that you may see is anywhere from the platelet problem or the clotting problem. And von Willebrand's disease, most common, 1% of the population. Think about it. It's the most common genetic reason for menorrhagia in women. OBGYNs are picking this up now because they're screening for it. So, again, these are the tests you can review. Hemophilia, I know A and B. Again, we treat it with recombinant factor. They're hemophilia centers and hematologists. Just remember that the problem we're having is inhibitors are developing. That's a big deal. All right, liver disease. Okay, tell your patients to stop it. What is it? No alcohol. Okay, 1 glass of wine a day keeps the cardiologist away. The whole bottle is bad. Stop it. These are all the things made by livers. So if you have somebody coming in a liver failure and bleeding, what do? Main thing you can think about is, again, I got to replace everything. So fresh frozen plasma, okay, maybe a way to give somebody else's clotting factors to your patient. But that's a major problem. You can try vitamin K, but you got to have a working liver to make that work. All right. And then thrombocytopenia, what makes platelets low? You can read about all these things. This is one you might see because it's common. ITP, idiopathic thrombocytopenia purpura. Kid has a viral episode, then is fine, comes running, playing, and now mommy sees these little spots all over them, and they're petechiae, and goes, ruh-roh. Takes them to the doctor, gets a CBC, their platelet count is like 30. You think the kid's got leukemia, what's going on? Usually this gets better in a week or two. Their platelet count just goes back if you do nothing. If it's too low, you can try steroids, and otherwise watch them, put them on precautions, but again, 80% go back to normal with just monitoring. So just know that one's out there. And then these bad boys you can review at your later thing. TTP, hemolytic uremic. Get help, please. HELP was for pregnancy. All right, and you ought to know that one. Table, yep, gave it to you. Bleeding therapy summary, low platelets, steroids, splenectomy if it's immune attack. I can give you transfused platelets if you need them. I can also give you recombinant thrombopoietin. And what are the others? What if I'm clotting too much? Stroke and embolus and all those things. Here's the clot chart. Dun, dun, dun. Okay. Virchow's triad, because everybody loves a test with triads on it. Stasis, injury, and hypercoagulable. That's all of our patients. Think of PVC pipes, platelets too much, vascular injury or clotting factors too much, or stasis and surgery. Okay, these are all the things that make you hypercoagulable. You can review the list. It's everything in medicine. The main genetic one I would file in my brain is Leiden factor 5. That is the most common genetic reason we can find when we do screening. It's activated protein C resistance. What do? Put somebody on lifelong anticoagulation once they declared. Also, heparin can cause a reactive, basically it's an immune attack against your platelets, and that can be fatal. So just remember, when anybody on unfractionated heparin get platelet counts, the first thing to happen, they fall. Then what you got goes crazy. So if you see a falling platelet count, stop the heparin, use another agent. Who are you going to call when you clot? Clot buster. TPA. Yay. Okay. But again, use TPA sparingly. Worry about the bleeding side effects. Heparin, we stop the clotting cascade. We can have unfractionated. That's the fastest way. We can stop the pump. Also, we've got low molecular weight, and we have fondaparinux as a non-heparinoid you can use when HIT is a problem. Thrombin inhibitors, again, these are the IV kind. We've had these for a while. They're very expensive, but they can work when you can't use a heparin. We have Coumadin, the most common oral agent. Again, interacts with every drug on the planet. You've got to have a functioning liver, and vitamin K. You can reverse it. If you give them vitamin K, stop the Coumadin, let it recalibrate. Monitor INRs. Coumadin is dirt cheap. It's the monitoring that costs. It's kind of the devil we know. All these new NOACs, they are now exam fodder because they've been out for over 5 years now. So really, I would know these work down here on factor 10 and 10A, and one of them, dibigatran, is a direct thrombin inhibitor. So they work down here in the common pathway. They're oral. They're once or twice a day dosing. The problem is we have not been able to monitor. We don't know what to monitor, and we only have one reversal agent right now approved by the FDA. That's for dibigatran. This is a little table to kind of compare and contrast. Look at that to see the differences and which one you may want to choose for your patients. They're becoming mainstream. Platelet blockers, again, we got so many ways. Aspirin by one is the best choice for cheap and effective. But if people can't take aspirin, we have clopidogrel, prasugrel, ticagrelor, all these others, dipyridamole, all these work at platelets at different sites. Just remember, if you give them a baby aspirin and an NSAID, you've doubled your bleeding risk, okay, because both of them are working against the platelet. So this is anti-clotting on a slide. What do you do for different things? MI and stroke prevention, it's antiplatelet. Stopping clotting for DVT, PE, MI, AFib, and genetic, you got to use something to stop clotting. That's heparin, low molecular weight, or the new thrombin inhibitors. Busting clots, TPA. So think of those three levels. And I think the rest of the slides are just a potpourri of things that they might throw at you. You got to know mono. We already talked about that in another lecture. They have atypical lymphs. That's the hematology part of it. Hodgkin's, again, lymphoma. Reed-Sternberg cells are the buzzword I would know. And then multiple myeloma, you heard from two other talks, so I won't go there. But they have rouleau formation, see, coin stacking. That's something I would commit to mind. All right, and then Bence-Jones protein. P-Vera, too many red cells, you worry about clotting. And why do you get too many red cells? And then the leukemias, the last thing I would know is, remember our bodies and AML. A is for AML. And then for chromosome, CML, Philadelphia chromosome in CML. ALL is primarily kids. Okay, so remember those kind of buzzwords. And that's pretty pictures. Okay, I think I'll get you to the boards. That will be your 3 questions. One of those we chatted about. So.